Right, so my name is Andreas Blomkvist. I sit on the advisory board for the Association for Safer Drug Policies. I'm also writing a book on the use of recreational drugs in medicine. I must say it's a great honor to share the stage with Ben, Luan, and David. Ben and Luan will focus on MDMA and ketamine, so I'll make a short and rather simple introductory lecture about how to balance risk and therapeutic potential with illicit drugs. You might think that this is a special area, but it is in fact principally no different than with drugs in general. And the reason is there's no bright line separating illegal recreational drugs from medical drugs. The effects of drugs, whether they be positive or negative, depends mainly on how they are used. And I can prove this to you, because even the most deadly substances in the world can safely be used therapeutically. Here you see an electron micrograph of a little rod-shaped bacterium called Clostridium botulinum. It might seem both beautiful and harmless, but they are not. They produce these neurotoxins that make their way into nerve cells and inhibit the release of neurotransmitters, resulting in muscle paralysis. Just a few nanograms of this substance is enough to kill a person. To put this into perspective, if you had a pure crystal of this substance, about the size of a grain of sand, you would have enough toxin to kill about 9,000 people. So talk about difficult dosing. You would also perhaps think that we didn't inject people with this, but we do. It is the active component in Botox, which is not only used for cosmetic purposes, but also different medical conditions. So you can ask, how have we made this deadly toxin into a rather safe medical treatment? Well, mainly by carefully diluting the neurotoxins, such that it mainly works only locally where it is injected. So what can we learn from this example? Well, the first thing is that drugs are not inherently harmful or beneficial, just like tools, like knives, are not inherently harmful or beneficial. The effects of drugs depends on how we use them, but we can say they have a potential. But to realize the potential, there's other factors in play. Therefore, one cannot directly compare medical use with recreational use. In clinical settings, we can control for risk factors for adverse effects, and therefore make a drug safe. To know how, we need to look at factors that interact to produce a certain outcome. One factor is, of course, the drug itself, how it is easy to overestimate the importance of the drug, because we know that the same drug can have different effects in different people, and also that the same drug can have different effects depending on how the drug is used. So different dose, how it is ingested, and in what context. To give you an easy example, opioids, as we know, are addictive. And when illegal drug users frequently use high doses of opioids, for instance, injecting it or smoking it, there's a very high risk of addiction. But what if we change who are using it and how they're using it and still compare the outcome? So if you compare the risk of addiction for all patients that have been given opioids in a clinical setting with the general public, there is in fact little or no increased risk of addiction. Does this mean that opioids are not addictive? No. It means that the risk of addiction depends on who and how the drug is used. So let's take another example. Cannabis. As we all know, recreational use of cannabis is associated with different detrimental effects, including abuse and dependence. But let's read what the FDA file has to say on Marinol, which contains a form of THC, and is one of the psychoactive compounds present in cannabis, and is abusable. We can also say that when looking at the medical literature, the FDA writes that no such decrements in psychological, social, or neurological status have been associated with the administration of Marinol capsules for therapeutic purposes. And they speculate in the sentence before that the etiology of these impairments is unknown when concerning recreational use, but may be associated with the complex process of addiction rather than an isolated effect of the drug itself. And it truly has been tested in an open-label study on AIDS patients, with many of them had a past history of drug abuse. No abuse, diversion, or systematic change in personality or social functioning were observed. This also agreed with a report by the European Monitor Center for Drug and Drug Addiction. They write about short-term risk, that in general the short-term adverse events reported were similar to those of other commonly used medicines. About the long-term risk, they write that there's less evidence, but in general those reported are similar to those reported for short-term use. And over time, more people report adverse events, but these are generally mild to moderate. And just as it is with adverse effects, the therapeutic effect also depends on how the drug is used. This man here, Humphrey Osmond, is a British psychiatrist working in Canada, pioneering the research on LSD and alcoholism in the 50s. So he used LSD in patients with alcohol use disorder. And after a lot of experimentation and testing, he learned that he only needed to give one single high dose of LSD to patients, and during some preparation, giving the drug in an aesthetic environment, and also having supporting monitors. He learned that when all these factors come into play, he could give the patient a psychologically transformative experience that made over half of the patients abstinent for months or even years to come. Other researchers were, of course, skeptical. They did not think that LSD had such an effect on alcohol use disorder. One such group was the ARF, Addiction Research Foundation in Toronto. They wanted to test Humphrey's theory, so they used LSD in alcohol use disorder, but they did a slight twist. They used a neutral room, they blindfolded the patient or restrained them, and they used extensive questionnaire during the session. Remarkably, the effect was mildly positive, but still, the skeptics concluded that, LSD isn't effective. But of course, this kind of misses the point about the treatment. Most of the therapeutic effects of LSD on alcohol use disorder is not to be found in the drug itself. It's not even to be found in the psychedelic experience, but in the interaction between the drug experience and the psychotherapy surrounding it. I'll give you now just a brief overview of the typical illegal recreational drugs, which is currently under investigation. You, of course, have cannabis, and here you see a list of the most researched clinical conditions. There's also psychedelics, primarily psilocybin. The 2 trials on cancer-related psychological distress is perhaps the most important, and because of these trials, the FDA have given psilocybin assisted psychotherapy the designation breakthrough therapy in treatment-resistant depression. Similarly for MDMA, the research is the farthest along when it comes to PTSD, where it is also have been given the designation breakthrough therapy. Lastly, there's ketamine with many trials on depression. To just give you an example on the modern approach and how to balance the risk and benefit with psilocybin, here's the Johns Hopkins group, their phase 2 trial on patients with life-threatening cancer in depression, and they had depression and anxiety. And they, of course, used psilocybin. And they used a lot of exclusion criteria. Just to give a few, they excluded patients with high blood pressure, because we know psilocybin transiently increase the blood pressure. They, of course, also excluded patients with previous psychotic illness or dissociative disorder. They also excluded those at risk for psychotic illness. They also knew that they needed to give a sufficient dose for a mystical experience, and to give a good placebo, they used a low dose to compare that did not give a mystical experience. They had preparation sessions and, of course, integration afterwards, and they gave it in an aesthetic living room-like environment with also supporting monitors. So what they found is truly remarkable. At 6-month follow-up, about 80% of the participants continued to show clinically significant decreases in depressed mood and anxiety after just one high-dose session. So there are some special benefits of therapy with psilocybin, MDMA, and ketamine. The research clearly indicates that there's a low risk for serious adverse events when used in a controlled setting. But this, you might say, is true for most other medical drugs, and you would be right. But what is truly special is that they do not require frequent dosing for high therapeutic benefit. And this substantially lowers the risk for long-term adverse effects, and in fact, is in principle a new paradigm in psychiatry. So that's all. Thank you.